Welcome to The Coalition. This is a talk show dedicated to discussing health, wellness, and inspiration. I'm your host, Dr. Shani Belgrave. Hello, everybody. Welcome to The Coalition. I'm your host, Dr. Shani Belgrave. I am a bariatric and minimally invasive surgeon in Atlanta, Georgia. You can learn more about me and get connected at www.drshanibelgrave.com. I am grateful and excited to welcome to the show today Dr. Malini Sur. Dr. Malini Sur is a surgical oncologist who specializes in the treatment of gastrointestinal cancers, including cancers of the hepatobiliary system. She joins us right on time for Pancreatic Cancer Awareness Month to let us know what we should know about pancreatic cancer. Dr. Malini Sur, welcome to the Coalition.
Thank you so much for having me.
Wonderful. I know that this is going to be a very impactful episode. Super excited to have a guest of your caliber on the show. Can you please start us off by telling us a little bit about who you are and what you do?
Sure. So I am a board certified complex general surgical oncologist, which means that I, after medical school, trained in general surgery like you did. And then I did a fellowship in surgical oncology. And my focus is on, as you said, the tumors of the gastrointestinal system, hepatobiliary, and pancreas. And so I evaluate and treat patients with diseases in this area. I perform surgery on them. I take care of them in the perioperative and postoperative period as well.
Wonderful. So can you tell us, why did you become a surgical oncologist?
That's a great question. When I was a teenager, I had a cyst. It was benign in my salivary gland. And I think that was the first time I kind of thought about being a doctor or being a surgeon. I'm lucky to have brilliant parents who both have PhDs in physics, but I saw how scary that time was for them, watching their child undergo a procedure. And I kind of saw the surgeon being able to come in and allay their fears and, put up my MRI and show me my insides. I just thought that whole process of being able to help connect someone to what's going on inside of them and calm them down was very exciting. And, I brought the MRI pictures to my ninth grade biology class because I thought it was so cool that, that there was this whole world inside of us that, if you don't get to go to medical school, you don't necessarily know all about. Later on, as I continued my training, I enjoyed surgery. My first exposure was through transplant. And ultimately, I felt that I really wanted to work with people who were sick and be in that role of being able to explain what's going on and help them through that process.
Well, that is very inspiring. Thank you for sharing that with us. So, as we move into the discussion specifically on pancreatic cancer, can you tell us about the incidence of pancreatic cancer, the prevalence, kind of what the numbers are?
Yeah, so although we do hear about pancreatic cancer a lot in the news, I think that we should keep in mind that overall it is still a very rare disease. And so in America, the
Mhm.
lifetime risk is about 1 in 55 to 1 in 60 people that will develop pancreatic cancer, which may sound like a lot, but is not as much as some of the other more common cancers. So, for example, the chance of getting breast cancer in the West is about 1 in 8. So it's still relatively rare. However, the rates are increasing, and because the other cancers that are more common have a lot more treatment options, the rate of death from pancreatic cancer is actually projected to rise and surpass some of the other cancers, certainly by 2030. And then of note, we are seeing higher rates of pancreatic cancer in younger patients. So we have some patients in their 40s and rarely in their 30s, which really, certainly when I was in medical school, was almost unheard of. So that's something that we have to keep in mind.
That's interesting. Do you have any ideas, or is it known why the cancers are showing up earlier?
I think it is a unfortunate trend that we're seeing across the board in GI cancer. So same for colorectal cancer. That certainly you may have seen that in the news. My perception is that it's not necessarily genetic. I think that, my guess would be it has to do with environmental factors like our exposures in our food and in our environment. And probably some degree is related to diagnosing these things also earlier than we did in decades ago, where a young person might never be able to have a scan and kind of figure out what's going on. But I'm mostly concerned about toxins and chemicals showing up in our environment and in our digestive system.
Hmm. And so that's kind of a great segue into the next question was going to be if you could give some insight into the risk factors for
Sure.
pancreatic cancer.
So I like to think of risk factors in terms of what you can change and what's harder to change. So things that you can change, we know that smoking contributes to pancreatic cancer, which kind of just the other day I had a patient who said, "Well, no one ever told me that. They told me to stop smoking, but they didn't tell me that my pancreas problems could be related." So obviously, we think of lung cancer with smoking, but the pancreas also sees it as a trigger. Related to that are sort of what we call the metabolic conditions like obesity, diabetes, and some patients have chronic pancreatitis, whether from drinking alcohol or from gallstone disease. And we know that smoking also plays a role in chronic pancreatitis. So I think those are the things that, obviously we can sort of work to try to modify by having a healthy lifestyle and diet. And of course, being active and not being sedentary. And then the things that are harder to change, certainly the chance of getting pancreatic cancer increases as you get older. It's slightly higher in men and in African Americans. And then I think the special category of something that you can't necessarily change, but maybe you can do something about is family history. So, although most pancreatic cancer is not genetic, I do think it's important to recognize the few that are. And part of the way that you can do that, if you're listening or watching at home, is by knowing your family history and really going back and asking about, the mysterious family members that you might have that might have passed, don't really know what happened, really try to get the history. And if you have a history of multiple cancers or anybody who died young of a cancer, what we call early onset, which is less than 50, it may be worth talking to your doctor about getting a referral to a genetic counselor who may be able to look through your history and understand whether you qualify for screening for these genetic mutations, things like the BRCA mutation, which we all know about, related to breast cancer, but also increases the risk of pancreas cancer. And actually, for those patients, especially as they get older, we have well-established screening protocols where we will actually check their pancreas with imaging and sometimes more than that to look for pancreatic cancer, things like blood tests, endoscopy, and imaging. And so those are, I see several patients a month probably for that. And it's something that we want to make sure we capture those few people that do have those risk factors so that they know that there's something they can do.
Absolutely. It's so interesting that family history has come up on almost every episode, with us saying that you really need to talk to your family, and see who
Right.
has what, because that can really provide key information that you're not going to find out otherwise. Um, so when we talked about pancreatic cancer, can you talk to us about the diagnosis? How can it be diagnosed?
So I would say the signs and symptoms are kind of what leads you to a diagnosis are related to the part of the pancreas that the tumor is in. And the pancreas
Mhm.
is deep in your back. It's shaped like a fish and kind of sits nestled in the kind of C-shaped part of the first part of your small intestine that's called the duodenum. So I always think of it as kind of the my fist here, kind of snuggled in that C shape, and that fist is the head of the pancreas. And then we talk about the body and tail out over here. The spleen is kind of up here on the left side of the abdomen. So patients who have tumors in their head of the pancreas classically will come in because it starts blocking off their bile duct, which runs through that area, and that'll lead them to turning yellow. And obviously, that's something that's very noticeable, and most patients just kind of wake up one day, and their family members will say, you got to go to the hospital. And other patients who have tumors in their body and tail, those can be actually a little bit more harder to find because it can grow there and not necessarily press on anything else to cause symptoms. But generally speaking, we talk about things like abdominal pain and discomfort, back pain, nausea, vomiting, unexplained weight loss is a big one for us. Sometimes tumors being in the pancreas can cause a deficiency in the way that the pancreatic enzymes get to your digestive tract. And so they can have missing pancreatic enzymes, and that can lead to weight loss and kind of foul smelling stools and things like that. So these are some of the more extreme symptoms, but I think a lot of the times it can be more subtle. And of course, we'll get to it's important to kind of know your body and pick up on those more subtle features. And in terms of the workup, if you do have some of these signs or symptoms, then of course, hopefully you'll get to a doctor soon. And usually the workup will include blood tests, looking at your liver tests, and something we call tumor markers, which look for cancer, full body CAT scan to look at the pancreas, but also look for other parts of the body to make sure it hasn't is not showing any signs of spread. And the diagnosis will usually come from a specialized endoscopy called an endoscopic ultrasound, where a advanced GI doctor can actually find the lesion or the tumor and put a small needle in it to get a biopsy and really tell us what's going on.
What point do you normally get involved? Is it after someone's already had an EUS, or are you ever involved earlier on when they have, jaundice and other things like that?
Yeah, I think it can be the full gamut. For the most part, most patients I'm seeing have already had some imaging. They may or may not have had their endoscopic ultrasound. I always it is, a balance. I think obviously we want to get patients in as soon as possible, but the more they've had done, the more I can tell them about what are we going to do next. If I see someone with no imaging, it's hard for me to really make a plan for them. But there are times that we will help to facilitate that. So I think the main thing is most patients actually go to their primary care or an urgent care or an emergency room if they're not feeling well. And as the workup kind of ensues, they'll get referred to either a medical oncologist, a cancer doctor, or a surgeon like me, or they might be sent to a GI doctor. So there are kind of different pathways. And again, I think just reiterating that we really want patients to know that they should A, see someone for a symptom, but also B, I do see a lot of patients that I see are kind of stuck in what I call I guess the delay in diagnosis kind of, wheel where they're going from one person to another person to another person. Each appointment's 2 to 4 weeks apart. Each test is 2 to 4 weeks away. And in that process, sometimes several months can go by. And so I think it's, a reflection, of course, of our kind of fragmented healthcare system. But anything you can do to advocate for yourself, if you're not getting your needs met, if you're not feeling well and you're needing help, I think being that person who calls their doctor back and says, hey, I really am not feeling well. I need something else to happen. If somebody tells you, well, we didn't see anything on the scan, you might want to get a second opinion or, seek additional tools and ways of diagnosing not just pancreatic cancer, but really anything. So, for example, I see patients also with gastric cancer, other forms of tumors. There are times that a scan, especially when it's not done in the ideal way, scan might not pick up on some subtle findings where you might need another kind of test. You might need an endoscopy. You might need an MRI. You might need more blood work. So there can be kind of funny situations. So if you're not feeling well, make sure to just keep advocating for yourself until you have an answer.
Absolutely. Advocacy is so important. And the more people know, the more they can advocate for themselves. So, you've given us some good insight into kind of the diagnosis, but then what are some of the different treatment options?
Sure. So I'll talk about that, kind of looking at where you are in your diagnosis. There are, I guess, a few patients that will come in with, a very early looking tumor that doesn't have any signs of spread on imaging. And they're also what I would call robust. They don't have a lot of medical problems. They've got good support. They're eating well. They haven't lost a lot of weight. They're ready for their big day in their operating room. So there are some patients that will go to surgery first. And for patients who have tumors in the head of the pancreas, that involves a complex operation that we often refer to as a Whipple procedure, where we remove the head of the pancreas, the first part of the intestine, the end of the bile duct, and the gallbladder, and the lymph nodes in that area. And when that's all out, we have to put them all back together by taking a piece of intestine and sewing it to the pancreas, the stomach, and the bile duct. And other patients who have tumors in their pancreatic body or tail, they will be able to have the left side of the pancreas removed, and that's often called a distal pancreatectomy. And often we take the spleen because the blood vessels to and from the spleen run right under the pancreas. So those are the operations, and some patients will be eligible to have surgery up front. But more and more, both because we see patients with somewhat later stages or middle stages, or patients who have gone through this 3 to 6 month period of losing weight and not being in the best shape, maybe having their diabetes not under control because it might have just been newly diagnosed. So those patients are not always ready or eligible really to go straight to the operating room. And more we realize that throwing people down for a big operation the day after you meet them doesn't always go well. And so for those patients, we really work on nutritional optimization, making sure we've touched base with all their medical doctors to make sure they're optimized for a big operation, but also plugging them in with the medical oncologist, because more and more we're finding that many patients need chemotherapy at some point in their treatment. And chemotherapy, if you don't know, is a kind of medication that treats cancer cells. And so many patients now are eligible to have some of that chemotherapy on their way to surgery. So first, before the big operation, and that'll help to give us some time to organize them, make sure their tumors are responsive and appropriate for an operation. In some cases, have their tumors shrink so that surgery is more likely to be doable or helpful for them. It also allows us time to work on that patient to get them to be optimized. Ironically, you might think, well, how could you get better if you're on chemotherapy? But with a lot of hard work, sometimes we do see that patients actually can, it's hard to go through chemotherapy, but if they know what the game plan is and they're working on nutrition and they're working on diabetes and all of their medical problems, they may actually come out at the end of that being better for the big day. And then lastly, I should say there are, of course, some patients that may not be eligible for surgery at all. Those patients may have chemotherapy. They may have radiation as a part of their treatment. And a small fraction of patients will get radiation before surgery. But for the most part, those are the big kind of 3 tools that most patients in America with pancreatic cancer will be seeing in their treatment course. There are these gray zones, right? We always want to have a clear-cut black and white answer, but many times in medicine, there are opinions and there are institutional preferences, doctor preferences, patient preferences that all have to be kind of taken into account. So we do have every week at our hospital, and any high volume pancreas cancer center is going to have a weekly conference where medical oncologists, surgical oncologists all meet together with the pathologist, the radiologist, the geneticist, everybody else, radiation doctors, to review the cases, the patient stories and their scans, and make a comprehensive consensus plan for them. But of course, the individual decision will come down to the doctor and the patient. So I always say the patient gets to have a say in what's going on, but we'll kind of talk amongst ourselves and make a plan together.
So, Dr. Sur, thank you so much for taking on what is a very complicated topic and breaking it down. What would be your takeaway message for viewers?
Well, I think the first thing is, the average person should not be running around worried about pancreatic cancer. I think we know that it has a bad rap because it's been hard for us to get more and more treatments to help people live longer and longer, but we are doing that. But for the average person, it's, something that I don't want them to be worried about, but I do want them to focus on what they can do to hopefully prevent pancreatic cancer and other related cancers, and also pick up on something early if, God forbid, you do get diagnosed with that. So, again, what that means is focusing on a healthy lifestyle, stop smoking, really minimize. More and more, we have data that really shows that alcohol causes cancer. And I think that's something that really hasn't made its way into the mainstream culture. It's still very, acceptable for us to go and drink on social occasions. And I think we, in the medical community and the social community, we also just have to kind of be more aware of that fact, which is that we should be drinking less and less and really trying to eliminate it altogether if possible. But also, maintaining a healthy weight, um, exercising. I know you're obviously a bariatric surgeon. I encourage people to think about options like bariatric surgery, especially if they're young and they're morbidly obese. We don't want to wait until they're 70 or 80 and then have other diseases and are, also dealing with obesity, because that complicates treatment. So there's lots of reasons to get obesity under control. Focus on activity, and try to be an influencer, right? Not only for yourself, but for the people around you, for your kids. Try to be the role model for them. So I think those are my take home points, really focusing on your health and being positive, knowing your history, and eliminating the things that we know we can change.
Absolutely, I agree. Taking on those modifiable risk factors, quitting smoking is one of the best things someone can do for their health. Obesity, unfortunately, has been linked to many cancers, including pancreatic cancer. So we're always trying to get to that healthy BMI. Dr. Sir, it has been a pleasure having you on the coalition. You're welcome to come back anytime. For viewers that are interested in connecting with you, what is the best way for people to reach out to you?
So I'm on Twitter and I'm on LinkedIn. The best way, really, if you're interested in, if you have a medical issue and you need me, the best thing to do is to call the office and get in for a consultation.
Fantastic. Thanks, Dr. Sir, for joining the coalition. Well, everybody, thank you so much for joining the coalition for another impactful episode. You can stay connected with me, Dr. Shani Belgrave, online at www.drshanibelgrave.com. Special thank you to Dr. Malini Sur, surgical oncologist. You can reach out to Dr. Sur by calling her office for a consultation. You can also follow her on social media. Thank you so much for watching. Make sure that you share this episode with at least one person to raise awareness for pancreatic cancer. I'll see y'all next time.